Thanks very much, David, and thanks to the organizers and all of you who are playing many of the leadership roles in building this field. And it's a pleasure to be with all of you this morning. Hopefully someone has my slides. Well, I can get started while they come up. So what I hope to do in the next few moments is to review a few of the metric sets that are out there and their characteristics. Talk a little bit about the challenges and the opportunities that those data sets and data systems provide. And then most importantly, talk a little bit about what I think is the most central part of this, and that's how do we go from measuring to actually getting something done, from measurement to action. So do I have this thing? Let's see. Got to figure out how to make it work. There we go. Okay. So I can't see those slides, so I'm going to, pardon me if I have to use my notes here. In many ways, this topic harkens back to what we've been talking about in public health for a long time, which is public health surveillance. And I put a definition up here. Hopefully this is the only slide that's got this many words on it. But I want to highlight a few of the salient points about public health surveillance, because I think it resonates with what we need to do. First of all, it's ongoing, so it's not a one-shot affair. It's systematic in the sense that we do this in a coherent fashion. It involves both the collection, the analysis, as well as the interpretation of health-related data, essential to the planning, implementation, and evaluation of public health practice. And for the most part, we have thought about that in terms of governmental public health. Oh, I've got them. Thanks. But beyond public health practice in a governmental sense, we're talking about population health here, of course, much more broadly. And it's closely integrated with the timely dissemination of those data who need to know them, and most importantly, actually apply that information and those data to prevention and control and improving health. And public health surveillance has a long tradition, and the basic uses that it's been put to are shown here. Part of it is just to understand the problem and figure out what the magnitude of the problem is and what's happening in terms of trends and patterns. Traditionally, it's been used to detect problems. I think most people think of public health surveillance in terms of infectious diseases and detecting outbreaks and changes, but it can be any kind of a problem, and we're certainly speaking of them more broadly here. To look at the distribution and extent of the problem, to stimulate us to think about what are the root causes of those problems, and help us to then conduct the kind of studies and research to understand or document those, find out whether those theories are correct, to stimulate control activities, and for evaluation. So I think those are all the kinds of things that we're talking about here. Many of you have seen this slide. Basically, we have many different conceptions of what a population is. We've tried to make the case that we should be thinking about this in the broadest sense as being the health of a total population, and the total population being that of a geopolitical area. We fully recognize that there are a lot of subpopulations that one is interested in, whether it's the diabetic population, people of low socioeconomic status, employed people, but those all represent subgroups, and we need to begin to think about the entire population when we think about these metrics, or at least recognize that whenever we're dealing with these subgroups, they are indeed a part of the problem, not really representing the broadest sense of a total population. Martha Gold chaired a committee with me, and some of you were on that committee, that tried to put a stake in the ground on measurement. The report is out on the table outside the conference room, but it identified really three major areas for where we need metrics. And I'm not going to take these quite in the right order here. When we talk about health outcomes, we often think about those as simply the sum, as the sum of the health of individuals. And traditionally, that's what we've thought about. And we could summarize that health in terms such as health-adjusted life expectancy, which is a summary measure of the entire population. Increasingly, though, we've realized that what we need to measure is not simply the health of individuals, but the conditions in which they reside. And what we need to look at is the health of communities more broadly, the social circumstances, the environment, the policies, and other things that are in place that reflect the health of communities. I would be remiss if I didn't take the advantage of the opportunity to talk about the work here in California that tried to figure out what a healthy community actually might look like. And this is a report that was done by the Department of Public Health here with the Sustainable Growth Council, I believe it's called, and a summary that was put together by colleagues here at the Public Health Institute. And I don't want you to read all of that. You can get it later. But basically, it talks about what we're talking about here. It's a healthy community provides for is a place that meets the basic needs of everyone across multiple dimensions. It provides a quality and sustainable environment and has health and social equity. So when we're talking about a healthy community and measuring many of these things, one of our challenges is to capture that breadth of what it takes to build a healthy community, or what a healthy community is, in a way that's succinct, understandable, and actionable. So, many of you have seen lots of metric sets, lots of data out there, and part of the challenge here is to try to bring some sense of coherence to all of that. And I'm going to try and walk you through in a few minutes some of the different ways that that's been done. But when we look at a metric set, I tend to think of those as an organized set of measures to assess and improve population health and equity, and that's what we're looking for. There are also core metric sets. And this is the definition of a core metric set that came out of the recent report from the IOM called Vital Signs. And I think it reflects a number of characteristics that we probably do care about. It's a parsimonious set of measures, so we don't want it to be endless, that provides a quantitative indication of current status on the important elements in a given field, and that can be used as a standardized and accurate tool for informing, comparing, focusing, monitoring, and reporting change. So I hope you see that in some ways as analogous to what we talked about in terms of surveillance. Metric sets themselves need to drive some sort of action if they're really going to serve their purpose. They've got to be compelling. They've got to reflect things that are the most important, that can help bring focus and stimulate action. There are a number of characteristics of these sets that are worth thinking about. The bottom part of this provides a set of descriptors for individual measures, many of which I think all of you resonate with you, that they're understandable, they're compelling, that they actually change, so you can see change over time. They have good technical characteristics. They're available at whatever level of the system you need them. But there's also a set of metrics. You also have to look at the characteristics of the set of metrics and how well that they reflect what you want to achieve. That is, they need to be comprehensive enough to cover the breadth of things of interest. They should be parsimonious. Can't be endless. People got to be able to wrap their heads around them. Again, they also need to be easily understood, and they need to promote the things that we care about: health, equity, and ways to improve the systems and systems change. So, before I go through some of those metrics, I think it's important to think about who develops those metric sets and why they do them. And there are lots of reasons why different groups develop metrics, and they differ somewhat. And that, in some ways, reflects why the metric sets don't align as well as we might expect. And it matters a great deal, whether you're a clinical care system, whether you've got a broad perspective like population health, whether you're interested in comparing different geographies, whether you want to do rankings, and you'll see many of these things come up in some of the descriptors that we talked about. So one of the initial sets that was was developed and certainly had a lot of most of you are aware of, are the topics that come out of Healthy People. These are the ones from Healthy People 2020. And what's interesting about them is they're not really organized in any general rubrics. They're a set of interesting topics of diseases, risk factors, some systems-oriented things, but it's a bit of just a list. And I think insofar as it is just a list, it can be useful, and it certainly serves their purpose in terms of monitoring the trends in those areas and for publicity, but it's hard to talk about this and say, is that really an accurate reflection of the kind of population health that we're really talking about? George Isham chaired a panel of the IOM that was supposed to come up with a set of health indicators for the state of the USA. And that group developed a set of measures that fell into a framework that looked like this. You can see the health outcomes that were on the right, and then the social, physical, environment, health-related behaviors and health systems on the left that were supposed to drive the kind of change that led to health outcomes, and then developed a set of measures for each of them. I should say that because this was part of what was going to be a much larger enterprise that looked at indicators not only across health, but transportation, education, and so forth, the actual measures for social and physical environment were deferred to another group. The other groups, unfortunately, those were never developed, so we don't see them. In some ways, those are both the most interesting and the most challenging to do in a parsimonious fashion. Some good move? I don't know. It's not going forward. Did I do something? I can talk, but it'd be nice to have some visuals. Anyway, I'll talk to you because I think the next slide is one that all of you have probably seen, and that's the county health rankings. You going? No. The county health rankings have been out for a number of years, and what I find particularly useful about them is that they separate out the health outcomes, which are length of life and quality of life, from the determinants, the health factors. Oh, there we go, that contribute to them, and I find it useful to look at how those health factors are divided up and the rough proportion of the health that can be attributed to them, so that we have the health behaviors, the clinical care, social and economic factors, and physical environment, all of which are familiar to all of you, but it puts in perspective what is generally perceived in this country as to be the relative importance of the clinical care system compared to all of the things that are in our environment that influence our behaviors and our health. And at the bottom, of course, are the policies, programs, activities that it'll take to move those health factors. And these are connected to the roadmaps and other kinds of evidence-based processes, and I think you'll hear more about those later. This is America's Health Rankings, which is sort of the partner to the county health rankings, and you can see their model. Again, has some of the same commonalities, but there are some differences, and this one tends to elevate sort of policy and combine some of the community and engagement or enforcement activities. The Vital Signs Report, which I alluded to a few minutes ago, which came out earlier this year, used a different framework, and partly this framework was based on the charge to that IOM committee. And you can see the general rubrics for the measures, which were healthy people, which generally meant community measures, health outcomes, and so forth. Care quality measures, that related to the clinical care system, the cost of care, because it was a central concern, and then this very interesting category called engaged people. There were some major challenges with some of this. It was hard to find measures. It was hard to even figure out what we really meant by engagement. People all thought it was quite important, but it was very hard to wrap our heads around it. This one, although it has some of the population health metrics, was done from a large, in my mind, and I guess you could think of, some others may differ, from a largely clinical care system perspective, and that's why there's so many of the care quality and cost measures. But it did bring to the fore the many things that it takes to build healthy people, and buried in there you'll see some of the social and environmental determinants that go along with that. There are also a lot of resources that have many, many measures that aren't necessarily organized in quite the same way. You'll see some of those, I think, at the back of your briefing materials. I'm just going to quickly highlight them. This is from the AARP. It's a Livability Index. It has many of the domains that are relevant to population health, and it sort of aggregates them in a sort of linear fashion without really talking about their relative weights, but has many good measures, certainly as a nice resource. In Los Angeles, we have recently launched a healthy community network, which comes out of the out of the group here in that has built these kind of websites around the countries, and you can see the kind of topics that it has, and it is basically a list of roughly 200 metrics that you can get at different levels. So it's a great resource, but it doesn't provide you really the kind of summary estimates that you might get for other purposes, but it's wonderful for doing some of the comparisons and getting some of the basic data. The Gallup Healthways WellBeing Index uses these domains, and it's a bit of a black box, at least to me. I wasn't able to figure out exactly how they get them there, but it's a big survey. It's done by Gallup, so it's very robust. But these, again, are some of the domains that it has. And I think it's particularly worthwhile noting this, and on the AARP one, they're talking about well-being more broadly than we tend to do. So you see things here like financial security that we haven't traditionally thought about in the health sphere, although obviously relevant. There's some also other data resources. I'm not going to go through all of them. One of them that was highlighted here is the National Equity Atlas, which again has lots and lots of data on equity, disparities, and so forth. So let me spend just a minute talking about some of the challenges with these things. First one is parsimony versus completeness. There's no good answer to what the right number of metrics is, but at some level you can't have everything. My own bias on all of this is the way we need to bring this together in a better way is to have some composite measures that you can then disentangle. So if we're going to measure the quality of the physical environment with an air quality index, that clearly is a pretty poor reflection of the other environmental issues, whether it's climate change, water quality, or our built environment. So we need some way to put it together so that we have the equivalent of some environmental health measure that would be equivalent to the consumer price index, that people, they may not understand how you calculate it, but they sort of know what it is and you can disentangle it when you need to. There's also a major problem with a paucity of good equity measures per se. Many of these information systems have a lot of information on different demographic groups, and you can analyze them so you can look at disparities. But if you say, how equitable is our community? It becomes very, very challenging to get those kind of measures, and I didn't find them in most of these data sets. Another challenge is that most of these are outcome-oriented, and I like outcomes because I'm sort of a surveillance outcomes kind of person, but outcomes don't change very fast, which makes them a little challenging for monitoring, seeing how well you're doing. And so we need to have some other measures to assess progress. And we need a set of process measures that are relevant to whatever it is that you're planning to do. There is a proliferation of these core metric sets. I've just given you a few here today, and you can get a sense of what they are, and they have a fair bit of overlap in some ways. But this proliferation is a bit of a challenge, I think, because it creates some confusion among many of our constituents, and we'd probably benefit from some authoritative leadership that pulls these together into a more coherent and smaller number that we use routinely and people become familiar with. Another challenge is the availability of the data at a level you can actually use. You'll see from the vital signs report that they're national data. America's Health Rankings uses primarily state data, the county health rankings, county data, but as we move down to localities where people really want that data so that they can use it in a much more concrete fashion in their communities, the data often get very scant. So it's a real challenge. So let's talk a little bit about linking metrics to action. And it's important if we're going to make progress, obviously, not just to sort of monitor the problem, but then to do something about it. The County Health Rankings does a great job, and as I said, you'll hear more about that later with its roadmaps that links these various metrics that they use into evidence-based interventions. Healthy People does that now as well. And we need more of that can provide direct people to the kind of evidence-based resources for policies, programs, and systems change. There's also the need to look at some of the components, actions and systems changes that are needed in the actual measures themselves. And you'll hear from Alonzo Plow in a minute about the work that the Robert Johnson Foundation has been doing as part of its culture of health and developing metrics for its action framework. And you'll see that they differ very much in type from the kinds of outcome measures that I've been talking about. And they really talk about the kinds of things that you need to put in place if you're going to be able to foster the kind of change. So it's a very different approach and a nice complement. And then, of course, we need to have detailed metrics that relate to the interventions that we're actually going to do. Here's a logic model from an IOM report on quality measures that are linked to the leading health indicators. And it really tries to go from the health outcomes that are being monitored by the leading health indicators to, well, what are the conditions you need to have in place if you're going to change those things? What are the interventions you're going to have to change those? And then what are the resources and capacities that you need if you're going to be able to implement the kind of interventions at a policy, program, or systems level? You'll have a test on this at the end of the presentation, but hopefully you'll be able to see it when you get to the slides. This is just how the logic model can be applied to a specific topic like tobacco use and the kinds of things that need to be put in place all along the way that can then be used. What is it that a healthcare system can do? What can a clinician do? What kind of policies need to be put in place? What kind of enforcement needs to be put in place? What do schools need to do? And you can then back up all these interventions that define the interventions, and you can select the interventions that you're going to do, and then talk about the resources and capacity it'll take to get you there, or oftentimes it's the other way. What are the resources and capacities you have that allows you to say, these are the interventions that we can actually do? And then you can attach metrics to each of those. And those are more local, and we could use some standardization of those too. But as you move from the right, which are the outcomes, to the left, things get pretty bushy and very large, and probably more local. So just to conclude, the best measures are the ones that drive action, that they provide the greatest health improvement and contribute to the health equity for the total population. The greatest opportunities to improve population health lie outside the traditional health sector in systems and policy change, and we need good measures there, or at least take advantage of the good measures that those sectors already have. We need to tie those measures to interventions. and preferably evidence-based interventions. And then they need to be part of a collective action process and quality improvement processes to drive change. And with that, I will turn it over to you, David.
Oh, thanks, Steve, for that great setup. And after these next two presentations, we'll then have time for questions of these three presenters. So next, I'm delighted to, technology permitting, to welcome Alonzo Plow, who is Vice President of Research, Evaluation, Learning, and Chief Science Officer at the Robert Wood Johnson Foundation. The last year, he's been the architect of what Steve just mentioned as their culture of health metrics approach. I think one of the most important things that's taken place in the last few years, and it's great that we're going to have a chance to hear from him. His board meeting coincides right today with with our workshop, and that's why he's coming to us virtually. And so I'm delighted to introduce Alonzo Plow. If you're out there, Alonzo.